Well, again, thank you, and my congratulations to Dr. Caselli for his phenomenal career and all the work he's done, and thank you, Dr. Ramaiah, for, again, inviting me back to the TED conference here. Again, I had the same question of the durability debt, and where is it really going here, and should we go early or late as we go through? Again, this is a privilege to really work with Dr. Caselli, because obviously he's laid the groundwork for a lot of this. And last year we actually debated, as you pointed out before, and I pulled his PubMed portfolio there, and I looked at it again this time, and showing how productive he is. He has 5 more pages of PubMed and about another 60 publications listed in that. So he's continuing to produce, continuing to add the literature. So truly it is an honor to be up here and having this discussion. It's really not a debate. Chuck Sternberg came back, and we got into irrational exuberance. And this is something that many of the people in this room remember back in the early days of EVAR. And we all said, well, you can't do EVAR, it has to be done in high-risk patients only. It's not going to last. And now we really talk about how hard it's going to be to get people trained doing open, because we don't do much in the way of open repair. So that's endo-exuberance has borne out, at least for the aortic aneurysm, despite what was been talked about in 2014 when this was first published with Dr. Sternberg. The thing I'm concerned about, and Dr. Caselli has already kind of commented on it, is early on, and we started with the TAVR. And something it was for high-risk patients, those that really can't have anything else done. The gold standard is truly doing the open aortic valve repair. And they looked at it from 2013 to 2021, and it got back to almost like a 50-50 of people having open aortic valve replacement rather than with the TAVR. Again, exuberance kind of said, well, hopefully we've now flatlined. And so it should be that we're kind of having some common sense. Some people need open, people need TAVR. Unfortunately, what happens is now it's 5-1. Not 50%, 5-1. So if you look at the data from 2023, there was 100,000 TAVRs being done and only 18,000 open surgical valve replacement, aortic valve replacements. So we're going further and further down, and I hate to say the number of times I've had patients come in, 92-year-old playing golf, and so yeah, I've got to get my valve replaced next week. I said, are you short of breath? I can play 18 holes and carry my bag. And I'm like, I'm not really sure we're going. So I think there's some exuberance we have to be cautionary about as we move forward for either of the technologies. Where does the future aortic aneurysm intervention? I think the surgical is, and Dr. Caselli has really kind of set the standards here of what we should do. They're conventional gold standard, high risk with complex procedures. This is not something that should be done in every hospital. Basically, it needs to be in centers of high volume and with excellent care. Very experienced surgeons, I said. You need to have the cardiopulmonary and the team that goes along with that as you do it, and then potentially even circ arrest as you go through, neuroprotection. This is the data I think is about as good as you're going to see. It's again quoted from Dr. Caselli. Perioperative mortality of 5%, neurovascular events 3.4 to 5.2, paraplegia 0.6% as you look at this. Renal failure, transient or permanent for 4.1%. Only thing I'd say is prolonged intubation because it's a bigger operation. But I think certainly we've seen that this is something that this is the bar, and everyone else needs to be measured to this bar because I don't think it should get much lower than this for open repair. For type A dissections, I think, and I commented on them earlier, when you get these short little interposition grafts, those are the ones that give us all concern, and now it becomes a redo median sternotomy as you go through. The hemiarches and the total arches, I think, are a much better procedure, but most of the type A dissections are done in acute situations. The cardiothoracic surgeon doing it at the time is like, I just want to get them off the table and I'll let someone else worry about it. So we get some of these incomplete repairs in centers that are not a high volume center. Considered for high risk for open repair, in people with significant cardiopulmonary disease, previous arch repairs, ascending repairs, severe COPD, and connective tissue disorder. These are all ones that we kind of think about, and connective tissues need open repair, but they're generally younger, and they don't have the other risk factors we go through. The endovascular, there's certainly risk, and we're working on trying to figure out how to lower that risk. Embolic stroke is probably the greatest thing we worry about as we go through, and the need for ancillary surgical procedures such as debranching. This is an article from Dr. Caselli, and saying these 3 decades of evolution going to more of an endovascular understanding and incorporation into his practice. And I think this is him being very thoughtful, and as we're going through it and say, there has to be some type of combination of endovascular and open, depending on what the needs of the patient is, not because that's what we can do. So we need to embrace either as a team or get the technology in the hands of the cardiothoracic surgeons so they feel comfortable giving all options as we move forward. And again, he's already quoted his Thoraflex data. This is 1-year data going out, really showing the advantage of a hybrid procedure of ascending repair with descending thoracic TVARs, all in one device. Dr. Joe came in and showed that we can do late conversions. So if you do an endovascular repair, it doesn't mean your open options are not there. It's more complicated, especially in the arch, but at least we don't have a lot of active fixation devices to deal with. So I think there is a way to come back and salvage, even if you have a failed endovascular repair. My corollary of that is generally those people getting endovascular repairs are those that are not considered good candidate for open repair. And so that becomes more of a question of if they have a complication with endovascular, what is their next option? And this is where we come in with, and this is kind of going down that rabbit hole of, well, I need to put more stents and I need to put coils and I'll need to pack it and try and take care of that type 1 endo leak or put an Amplatzer plug in. So we are trying to do more and more endovascularly, but it's generally in those patients, or should be in those patients that are not candidates or were never candidates for open repair when the pathology was originally detected. And this is, again, he said, of the 538 TVARs that he did, he had to have 33 that had to actually do explantation. Two of those 33 were transferred to him, but he was able to do, and of those, he required circulatory arrest in almost half of them. He had a stroke rate that was around 6%, a paraplegia rate around 3%. But their survival was going out at 1 year at 84% and 67% after salvage, and this is more for the thoracoabdominal thoracic, but certainly there is a role if we can come back and salvage with open in some cases. Collaboration, and we've already talked about, and Dr. Oderich is now down at Baylor, and I think this is really the role that we need in the model we need to be seeing. High quality people working well together to try and do what's best for the patient. And again, I'm going to go back and say these centers of excellence are really, for something like this, we really need to be pushing to. And everyone says, well, I think a center of excellence is a good idea as long as I'm one of the centers. And I think there's going to have to be a way of saying you need to have the cardiothoracic surgeons, the vascular surgeons, the anesthesia, the critical care, the medical people, cardiology, all those working together to make it a good collaborative environment to really treat these complicated cases. Excuse me. So some of the original data, the Gore tag device is they have 2 portal sizes you can use. And this is what we originally did some of our first zone zeros with. Originally came out for zone 2, and then we now got approved for zone 1 and zone 0. We've just presented some of this at Southern, where we're able to show that you can do this for these high-risk patients in going into zone 0 and zone 1. They had a good 30-day data. As you look at it, their stroke rate was 3.6%, and the technical success was 91 to 97%. These are some data coming outside the trial later being presented, but I think these are all things showing that we can do this in the right patients that aren't good candidates for other interventions. Now, one thing when you look at, and you look at this series, and I'm going to jump through the original data here, they were mainly aneurysmal disease. They were elective in more cases, but the main thing, previous ascending repair in 60% of the cases. So again, this is another solution coming in for those people who have failed, and it has to be done collaboratively to move forward with it. The 1-year outcome was actually quite good. You look at, they had type 2 endoleaks was really the only complication, similar to what I talked about with some of the Nexus studies. So I think if you get the right patients and the right indications, even if they've had previous arch procedures, you can do endo to at least salvage them to move forward and give some quality of life as they go forward. but again, we don't have 10-year data. I've already covered this, so I'll go through this quickly. The Nexus series, certainly looking at it. Again, this is the big thing I want to say is you're not cannulating the cerebral vascular circulation as you do this. And again, the big push is the thing that drives my heart rate up when we're doing these procedures. But again, you can come in and you can do this. Now, the real thing is I want to look at this is that you can say even within the Nexus trial, and I went through, the point is they had prior sternotomy in half the cases, and you had a history of previous aortic intervention in almost 60% of the case. So we can work collaboratively. Some of these patients are not going to do well. They end up with, I had, a couple of my patients had that short ascending graft and didn't want to do a redo median sternotomy, and so this was something we did with the Nexus graft, and I think that worked very well. Again, complication rates is relatively low, but again, these are very carefully picked patients. But all of them in our center, and I think in most of the cases, were told they were not a surgical candidate by the cardiothoracic surgeons. And so disabling stroke, and this is where I want to get in a little bit more detail, is that we say, well, for the single branch, there's always a stroke risk associated with doing the carotid subclavian, or I do carotid subclavian with carotid reimplantation. But in the trial, there's only one patient that actually had a stroke from the surgical procedure. That was, once they're enrolled, then they got their carotid bypass. Only one patient had a stroke. So it's a very safe procedure in qualified hands to do that extra anatomic. And so I'm getting more concerned about trying to do 2 and 3 vessel when we can do 1 vessel endovascularly and then do the extra anatomic bypasses that we've done. So I think, again, this is, we're going to find the endovascular in the right case and the right patient is a good way to go if they're not a good candidate for open repair. As we get 5-10 years data, we may go from that, but I certainly do not want to see that exuberance we're seeing with aortic valve percutaneous aortic valve position, because I think they're going way too far. And then the endobental is going even further, and that was discussed earlier, so I'm going to save time and move forward with that. But this is something where they're now trying to find out how to go all the way down to the valve and try and do the coronaries too, and it's going to be a very selective case as you go through. And here you can see them basically positioning the endobental as they go through. So in conclusion, I think open endovascular intervention both have a role as we move forward, and it needs to be in a high-quality center, high-volume center. You need excellent collaboration between the vascular and cardiothoracic surgeons so we can evolve to work in a thoughtful group that work closely together. And the endovascular exuberance needs to be curtailed as we move forward to make sure we're doing the right thing for the patient, not because it's a fun thing to do. And so in conclusion, I think we've shown that endovascular aortic arch therapy is shown to be effective and safe therapy for primary and even for rescue after open arch repair. It's not recommended changing or lowering the indications. I don't want to say, well, you would do a open repair if he was of this size, and then say, well, but it's endo, it's minimally invasive, we can go lower in size. No, we should not change it. We should stay with the same guidelines we had. An endovascular option for patients considered too high risk for open repair is reasonable. And I think Dr. Caselli is an exceptional open aortic surgeon who is evolving into an excellent endovascular surgeon also. So thank you very much for your time. And Dr. Caselli, I really appreciate the opportunity to be here with you. Thank you.
Guys, so who won the debate?
We don't know yet.
It was a discussion. You know, he referred to me as evolving endovascular surgeon, but I was the PI at Methodist Hospital for the first endo trials, abdominal and thoracic. Venky, give me just 1 second, though. Frank has been sitting over here very quietly. He's been listening to all of these, and he hadn't had a chance to. So, Frank, give us some thoughts on these things. Give us some wisdom.
On your debate?
Yes, regarding the durability debt.
Yeah, I'll give you a couple things that I would get from these talks. One, if you're going to do laser in situ fenestration, which was shown up here, I'm not against the Cook device, but I think it's the hardest device to do laser in situ fenestration because the stents are stacked on each other. There's very little space. So I would use either Endurant or Terumo. I think that's better. One question for Dr. Caselli with the Thoraflex. Some of the things that we've seen, it works very well, but I've seen a little bit of clot form in the distal stent while I'm waiting to put the stent in. I haven't had any complications from that. Do you think that stent needs a little bit different design to give it a little bit more radial force, or what's your experience with that?
Yeah, well, first of all, my experience is, I went back and looked at all the patients that we put in the trial ourselves and all the follow-up. Now, I didn't see any thrombus in any of them. We've put in, I don't know, dozens and dozens and dozens since then, and we haven't had any problems. So there must be a patient selectivity issue that there's been some reports trying to sort out. Maybe it's in women of smaller stature, larger aneurysms, maybe grafts which are disproportionately large for the laminar flow, et cetera. So I really don't know the complete answer, but it is a worry that's being investigated, and I think a number of, the Canadian paper, they incriminated embolization because they had distal embolization, but actually there was nothing in the graft, and they made the assumption it came from the graft and then distally embolized. And so I'm not sure you can really connect the 2 points, but it is an issue, and we need more information on it. And with redesigning the graft, I doubt that's going to be done. But yeah, there are some specific issues with the design of the graft which may contribute to this particular problem. Absolutely.
Yeah, in fact, I think Dr. Parodi is working on a totally different material for stent grafts. We only have PTFE and Dacron. I mean, these materials have been available for so long. I think we need something totally different, not even for leg bypasses.